Hey everyone! If you're prepping for your ATI or NCLEX exams, you are in the right place. Today, we're diving into pediatric GU disorders with a super high-yield, rapid review. We're going to cut right to the chase and focus on the key concepts you absolutely need to know to nail those tough peds questions. Let's get into it. So, to really get a grip on this topic, we have to start with this fundamental question. Why is it that kids, and especially the really little ones, are so much more vulnerable when it comes to their urinary system? The answer isn't just one thing. It's really a combination of factors that are all rooted in their unique developing anatomy and physiology. And that's the perfect lead-in to our first section. See, before we can understand what goes wrong, you've got to first master what makes a child's GU system different from an adult's. And let me tell you, these differences are classic exam topics because they directly explain the risks involved. Okay, this slide is absolutely critical because every single point here is a direct setup for a potential problem. First off, their kidneys are proportionally huge and have less fat and red protection, which makes them way more susceptible to injury. Second, that shorter urethra, especially in little girls, is like a super highway for bacteria to zip right into the bladder. That's why UTIs are so common. Third, a slower GFR in infants means their little kidneys just can't concentrate urine or handle fluid shifts as well, putting them in a massive risk for dehydration. And finally, that tiny 30 ml bladder in a newborn, it means they void constantly, so any problem becomes obvious much faster. The bottom line is, their anatomy dictates their risk. Okay, so now that we know why they're at risk, let's look at what can actually go wrong. We can basically group these issues into two main buckets: structural problems that they're born with and acquired disorders that pop up later. Let's start with a big one: vesico-ureteral reflux, or VUR, and it's exactly what it sounds like. Instead of urine being a one-way street out of the body, it actually flows backward from the bladder up toward the kidneys. This is a major setup for recurrent UTIs and even kidney damage because it lets bacteria travel to places they should never ever be. Next up, we've got two conditions that are so easy to get confused on exams: hyposphadias and episphadias. The only real difference is the location, and you have to know it. Here's a simple way to remember. Hypo means below. So in hyposphadias, the opening is on the underside. Episphadias is on the top, or dorsal surface. Both are congenital issues that need surgery, but knowing the location is key. Now let's shift to an acquired disorder that is a true pediatric emergency: hemolytic uremic syndrome, or HUS. This usually follows a really nasty bout of E. coli-related diarrhea. What happens is the bacterial toxins get into the bloodstream and just start shredding red blood cells, which then clog up the tiny filtering system in the kidneys. And this slide shows you the devastating result. You absolutely need to commit the US triad to memory. First, you get hemolytic anemia from all those destroyed red blood cells. Second, you get thrombocytopenia because the platelets are getting all used up trying to form clots in the damaged blood vessels. And third, the direct result of all that clogging is acute kidney failure. This triad is the absolute signature of HUS. All right, let's talk about a very common but often misunderstood issue: enuresis. It's not just bedwetting. We classify it. Primary enuresis means the child has never been consistently dry. Secondary is when a child was dry for at least 3 to 6 months and then starts having accidents again. This often signals some underlying stressor or a medical issue. And then, of course, we distinguish between diurnal, which is daytime accidents, and nocturnal, which is nighttime bedwetting. So how do we spot these problems early? Well, it all comes down to assessment. Let's move on and look at how these disorders actually present. What are the key signs and symptoms that we need to be on the lookout for? First, let's look at the clues that are directly related to urination itself. A child complaining of burning, a sudden change in their voiding patterns, or foul-smelling urine are all classic signs of a UTI. And remember, a baby can't tell you what's wrong, so these objective signs are so important. Any visible blood is an immediate red flag that needs to be investigated right away. But it's not always that obvious. GU problems can cause symptoms all over the body. An unexplained fever is a huge one in infants. Swelling or edema, especially around the eyes, can signal kidney issues. Flank pain points directly to the kidneys, and poor growth can be a really subtle, chronic sign that the kidneys just aren't functioning the way they should. All right, time for a quick knowledge check. A nurse is percussing a child's abdomen and hears that dull sound that means a full bladder. Based on what you know about anatomy, where would this sound be heard? Is it A, B, C, or D? And the answer is D, above the symphysis pubis. This is a fantastic assessment skill to know. Normally, that area is filled with bowel, so it sounds hollow or tympanic. But when the bladder fills with urine, it rises up out of the pelvis, pushes the bowel aside, and creates that dull sound. Great job if you got that one right. Now we have to talk about the most serious outcome of these disorders. What happens when the kidneys simply can't keep up and they start to fail? So kidney failure is basically when the kidneys can't do their three main jobs: concentrate urine, balance electrolytes, and get rid of waste. When this happens, all of a sudden we call it acute. But if the damage continues, it can become chronic and eventually lead to end-stage kidney disease, or ESKD, which is when the kidneys have essentially stopped working. So, as nurses, what's our role in all this? How do we care for these kids, especially the ones with chronic conditions? This brings us to our final, and maybe most important, section, our nursing priorities. When a child has ESKD, our care is incredibly holistic. Yes, of course, we manage the technical side, like dialysis, to remove waste. But just look at the rest of this list. We are laser-focused on promoting their growth, which is often stunted by kidney disease. We meticulously manage their nutrition and fluids. And just as importantly, we focus on their psychosocial health and provide constant support and education for the entire family. It's a massive team effort. Okay, one last clinical pearl for you, framed as a question. This is something you will definitely see in practice. True or false? You listen to a child's hemodialysis fistula and you hear a bruit, that whooshing sound. Is this a good thing? The answer is absolutely true. That bruit and the thrill that you can feel are the signs of life for that fistula. They tell you there's strong, turbulent blood flow, which is exactly what you need for dialysis. The absence of a bruit or a thrill is a clinical emergency because it means that fistula has clotted off. What you hear or don't hear can literally change everything. And that really brings us to the core takeaway for today. In pediatric nursing, knowing what's normal is the only way you'll ever be able to spot what's critical. Whether it's the sound of a fistula, the location of dullness over a bladder, or the subtle sign of poor growth, your assessment skills are everything. Thanks for joining me, and good luck with your studies.